We'll be breaking down all major concepts covered on the exam.
Mm.
Usually when we talk about human anatomy, there's this expectation of, like, perfection. Think of it like a medieval fortress. Your skin is the castle wall. Its entire job is to keep the invaders out and the vital resources safely locked inside.
Right, exactly.
And when it works, you don't even think about it.
Mm.
But then you step into the world of dermatology, and suddenly that fortress is under siege. You are looking at a landscape where the walls are crumbling from the inside, the guards are confused, and honestly, the diagnostic waters can get incredibly murky.
I mean, it is the absolute definition of diagnostic muddy waters, especially when you're staring down a multiple choice question where literally every answer just looks like a red, itchy rash.
Which is exactly why we're here. I'm Harvey.
And I'm Donna.
We are 2 MCCQE reviewers, and our entire goal is to help you, the Canadian medical student, feel a lot more comfortable with the exam review process.
And before we jump into the trenches, we do need to explicitly state that this deep dive teaches from reliable StatPearls articles focusing on dermatitis. So specifically atopic, contact, seborrheic, and Lichen Simplex Chronicus.
Yeah, got to keep the lawyers happy. So please remember,
Yeah.
This is for medical education only, not medical advice. Any clinical decisions out there in the real world should always involve a qualified healthcare provider.
Absolutely. So with that out of the way, let's talk about our mission for you today. We want you walking into exam day mastering the high-yield eczema and dermatitis concepts.
Right.
That means knowing the definitions, the classic presentations, the management, and, most importantly, the common exam traps the boards absolutely love to throw at you.
So let's start with the fortress crumbling from the inside out.
Mm-hmm.
Atopic dermatitis, or AD. This is the most common chronic inflammatory skin disease, and it's not just a superficial rash. It originates from a fundamental genetic and immune vulnerability. It's an endogenous defect.
Yeah, and that internal defect is exactly where we have to start if we really want to understand the pathophysiology. The root of the problem is a barrier defect. Specifically, it's a loss-of-function mutation in the filigrin gene.
Filigrin? I mean, that sounds like something out of a fantasy novel. What does it actually do?
Well, it stands for filament aggregating protein, and normally it breaks down into natural moisturization factors right in the epidermis.
Okay.
So if you combine a mutation in that gene with decreased levels of ceramides, which are, the crucial lipids in your stratum corneum, you end up with a structurally unsound barrier.
So if we go back to our castle wall analogy, imagine a perfectly healthy epidermis is a solid brick wall. The skin cells are the bricks, and the filigrin and ceramides make up the mortar holding it all together.
That's a perfect way to look at it.
And in atopic dermatitis, that mortar is just crumbly. And because it's defective, water simply leaks out. That causes transepidermal water loss, which leads to severe dry skin or xerosis.
Right.
And worse, if water can get out, microscopic invaders can just walk right in.
And that structural failure, that's what sets off a massive immunological chain reaction. When those invaders, so allergens, irritants, microbes, when they breach that crumbly mortar, they trigger the immune system.
Right, the alarm bells go off.
Exactly. But the immune response isn't static. It evolves over time. So in acute early lesions, we see an overactive Th2 response driven by cytokines IL-4 and IL-5.
Wait, back up a second. Why does the immune system change its entire strategy just because the rash has been there longer? Like, what actually happens in the chronic phase?
It's a really great question. Think of the Th2 response as the initial panic. It's the alarm bells ringing when the breach first happens. But if the wall is never repaired, the body sort of settles into a state of chronic, entrenched warfare.
Oh, wow. Okay.
Yeah, the cellular signaling shifts entirely. In chronic lesions, it becomes a Th1 response, and that's dominated by interferon gamma and IL-12. So the local microenvironment of the skin is just totally thrown off.
And it isn't just allergens getting in, right? We're talking about bacteria taking up residence, too.
Yes, and this is a major exam concept you need to know. Because of that defective environment, these patients actually have decreased antimicrobial peptides in their epidermis.
Like what specifically?
Specifically human beta-defensins and cathelicidins. And as a direct result of that, over 90% of atopic dermatitis patients have Staphylococcus aureus colonization on their skin.
I mean, that's a staggering percentage. So they are literally just walking around coated in staph.
They really are.
Yeah.
And that Staph aureus worsens the underlying inflammation, and it frequently leads to secondary impeteginization.
Okay, let's translate that for the listener really quickly.
Yeah.
Impeteginization basically means a secondary bacterial infection has set in on top of the raw, inflamed skin. And that often creates those classic honey-colored crusts.
Exactly.
Okay, so that is the underlying mechanism. Yeah. Now let's talk about how this actually looks on a patient, because the clinical presentation is a classic MCCQE trap. It completely changes depending on the patient's age.
It does. In infants, you're looking for edematous papules and crusts primarily on the face, the scalp, and the extensor surfaces of the extremities, so, the outsides of the arms and legs.
And here is the crucial exam trap you need to highlight in your notes right now. Infant atopic dermatitis rarely affects the diaper area.
Yeah, that's a huge point.
Why? Because the moisture trapped inside the diaper actually protects and hydrates that defective dry barrier.
Right. It acts like an artificial seal.
Exactly. So if a vignette describes a severe rash in the diaper area of a baby, pivot away from atopic dermatitis immediately. You need to be thinking about things like candidiasis or seborrheic dermatitis.
And that distinction will absolutely save you points on the exam.
Yeah.
Now, as that infant grows into an older child or an adult, the presentation shifts geographically.
It moves around.
Yeah, the lesions move away from the extensors and into the flexural areas. So we're talking the antecubital fossa inside the elbows, the popliteal fossa behind the knees. And because it's been itchy for years, the skin becomes lichenified.
Lichenified meaning it looks like tree bark, right?
Yeah.
Thickened plaques with very prominent enhanced skin markings just from constant rubbing.
Exactly. Adults particularly get this severe thickening on their hands.
So how do we treat a wall with crumbling mortar? I mean, we have to artificially spackle it. We use emollients applied at least twice daily. But the physical timing of the application is a high-yield detail here.
Very high yield.
They need to be applied within 3 minutes of exiting a lukewarm bath to trap that ambient moisture right into the skin.
And for the acute inflammatory flares, topical steroids are first line. But here is a key clinical pearl for you. You have to instruct the patient to apply the topical steroids before the emollients.
Oh, right, because the emollient goes on top to sort of lock in the medication.
Exactly. But you run into a big problem when you're treating sensitive areas like the face, the axilla, or the groin. You cannot use high-potency steroids there long-term.
Because it causes telangiectasia and skin atrophy. Basically, the skin thins out to the point of being almost translucent, and you get those permanent visible spider veins. So what do we use instead?
That is exactly when you switch to topical calcineurin inhibitors like tacrolimus. They calm the local immune response without thinning the skin. And for really severe systemic cases that don't respond to topicals at all, we now have biologics like dupilumab.
And that's the one that acts as a monoclonal antibody, specifically blocking that IL-4 receptor we mentioned during the acute Th2 phase, right?
You got it. It blocks that whole early cascade.
Okay, I need to push back on something here, though. We've established that atopic dermatitis is fundamentally the dry skin problem, a lack of moisture and lipids.
Right.
So why do board vignettes sometimes describe a patient with a known history of AD who suddenly develops a rapidly spreading cluster of, vesicular, weeping, fluid-filled blisters? That seems completely contradictory to the whole dry skin mechanism.
It definitely seems contradictory until you look at the microbiology. When you see a sudden explosion of vesicular weeping lesions on a patient with atopic dermatitis, you are no longer just dealing with eczema.
Okay.
You must immediately suspect Kaposi varicella-form eruption, which is also known as eczema herpeticum.
Oh, so a secondary virus has basically entered the chat.
Exactly, and it is a medical emergency. What happens is a primary herpes simplex infection takes advantage of that defective skin barrier. Because the mortar is missing, the HSV virus isn't contained at all. It just rapidly and aggressively spreads across the vulnerable epidermis.
Oh, wow. So the weakening fluid is actually from the viral blisters.
Yes, and it requires prompt systemic treatment with a cyclover to prevent severe systemic morbidity.
That makes perfect mechanistic sense, actually. The wall is broken, so the invading army just rushes the courtyard.
Yeah.
Okay, so that is atopic dermatitis, which is an endogenous genetic defect.
Right.
But what if the wall is perfectly healthy and the invaders are simply overwhelming? That brings us to contact dermatitis, which is an exogenous assault.
Yeah, and contact dermatitis is broadly divided into two major categories that you must be able to differentiate on a vignette. Irritant contact dermatitis, or ICD, and allergic contact dermatitis, ACD.
Let's look at the irritant side first. ICD accounts for up to 80% of occupational dermatitis. What is the actual mechanism of damage here?
ICD is a direct, toxic, degenerative effect right on the epidermal cells. I mean, think of it as chemical warfare.
Wow.
There's no immune sensitization required, no T cells are involved at all. It is simply a chemical like sodium lauryl sulfate in soaps or harsh industrial solvents, physically stripping the lipid layer and directly damaging the keratinocytes.
It's like pouring acid on the castle wall. The wall was built perfectly fine, but the acid just burns right through the stone. Anyone's skin would react to the concentration or duration of the chemical is high enough.
Exactly.
And because it's direct chemical damage, the timeline is fast. It peaks within minutes to hours of exposure. But allergic contact dermatitis is a totally different beast, structurally speaking, isn't it?
Completely different. ACD is a delayed type 4 hypersensitivity reaction. It is strictly T-cell mediated.
Right.
So for this to happen, the patient must have been previously sensitized to the allergen at some point in their life. The first time they touch it, nothing happens, but their immune system basically catalogs the threat.
So when they are re-exposed, what exactly takes so long? Why is it delayed?
Well, because it's a really complex, multi-step immunological process. The antigen-presenting cells in the skin have to capture the allergen, then migrate to the lymph nodes, show it to the memory T cells, activate them, and then those T cells have to physically travel back to the skin to trigger a massive inflammatory cascade. That intelligence gathering and trip deployment just takes time. It takes 24 to 72 hours post-exposure for the clinical lesions to actually appear.
And that timeline is your biggest diagnostic clue on the exam. Minutes to hours equals direct irritant damage. Days later equals an allergic T-cell response.
Okay.
Let's talk about the classic exam triggers for allergic contact dermatitis. In North America, the undisputed king of ACD is poison ivy, or toxicodendron. The specific allergen is urushiol oil.
And here is where a careful history completely dictates your clinical advice. If a patient realizes they just brushed against poison ivy, washing the area vigorously with regular soap is actually highly effective at preventing the rash.
Really? Just regular soap?
Yeah, but it must be done within a strict 2-hour window.
Wait, why 2 hours exactly?
Because urushiol is incredibly lipophilic, so within 2 hours, it chemically binds to the epidermal proteins, and once it's bound, you cannot wash it off.
And if they miss that 2-hour window and those classic linear fluid-filled vesicles form, the exam trap is thinking you can just prescribe some low-potency hydrocortisone to fix it.
Oh yeah, that won't work.
Because once those vesicles are fully formed, the T-cell cascade is already peaking. Even high-potency topical steroids are of very little use in significantly reversing the symptoms at that stage. You're largely just riding out the immune response and treating the symptoms.
Right. And another extremely common trigger you'll see on the boards is nickel, which is often from cheap jewelry or belt buckles.
Oh yeah, classic.
There is a really neat clinical diagnostic trick you can use here. You can test a patient's jewelry using the dimethylglyoxime test.
Dimethylglyoxime, right?
Yeah, you just put a few drops of this solution on a cotton tip applicator and rub the metal in question. If the applicator turns pink, the jewelry is leaching nickel.
Just a little rapid bedside chemistry. But the true gold standard for diagnosing allergic contact dermatitis is patch testing, right?
Yes, absolutely.
You place these little metallic thin chambers on the patient's back, which are loaded with diluted common allergens. But again, you don't read the results immediately.
Right, because of the delay.
Exactly. You remove the chambers at 48 hours to check for an initial reaction, and then you read the final results 48 to 72 hours later. It perfectly mirrors that delayed type 4 timeline we just talked about.
Yeah, it lines up perfectly.
Yeah. As for treatment, it mostly comes down to strict trigger avoidance. High-potency topical steroids, being very careful, obviously, to avoid thin-skin areas like the face or genitals to prevent that atrophy we discussed, and systemic antihistamines just to suppress the itching.
Which actually leads us perfectly into our next concept. We have been talking a lot about intense pruritus, the severe, maddening itching seen in both atopic and contact dermatitis.
Right.
But let's zoom out. What physically happens when that intense itch or even just profound chronic psychological stress drives a patient to habitually scratch the exact same area of skin for months or even years?
Well, that brings us to the mechanical consequence of itch, which is formerly known as Lichen Simplex Chronicus, or LSC.
Yeah, LSC is essentially chronic neurodermatitis. It is entirely driven by a vicious itch-scratch cycle. A patient experiences a localized itch, and this could be from an underlying primary dermatosis like eczema, or it could be purely psychogenic, stemming from emotional stress or anxiety, and they scratch it.
And scratching feels good for a second. It temporarily relieves the itch. But what is it actually doing to the tissue?
Well, it mechanically damages the keratinocytes. That damage releases highly inflammatory cytokines into the local tissue.
Okay.
Those cytokines then stimulate the peripheral nerve endings, which the brain perceives as more itch, which then drives more scratching.
It is exactly like lifting weights. If you constantly create mechanical friction on your palms by lifting heavy barbells, your skin defends itself by forming a thick, hyperkeratotic callus.
That's a great analogy.
LSE is basically a callus born of neuroperception and anxiety. The skin gets wildly scaly, thick, and hyperkeratotic. The color can vary wildly, but it often develops what we call a leukodermic center.
Right, leukodermic meaning a pale, depigmented central area where the skin has been repeatedly traumatized, surrounded by a darker, hyperpigmented outer zone.
Yeah.
And here's the absolute key diagnostic clue for your multiple choice questions. Because LSE is mechanically induced by the patient's own hands, it almost exclusively appears in self-accessible areas.
Because if they can't reach it, they can't scratch it.
Exactly. You will see it on the scalp, the back of the neck, the extensor forearms, the lower legs, and the genitals. You will never, ever see an LSE plaque perfectly centered in the middle of the back where the patient's hands just can't reach.
So how do we treat a rash that is fundamentally driven by a behavior? I mean, breaking that mechanical cycle has to be priority number one. We use high-potency topical corticosteroids, but we often use them under occlusion. We literally wrap the area in a physical dressing, sometimes even saran wrap, for up to 3 weeks.
Yeah, and that occlusion serves a dual purpose. First, it forms a physical barrier that just stops the patient's fingernails from further damaging the skin. Second, the occlusion increases the hydration of the stratum corneum, which forces that topical steroid much deeper into the thick calloused plaque.
We also use medications like doxepin or systemic antihistamines, mostly for their sedative effects, just to calm the pruritus at night.
Right.
But importantly, managing the underlying psychological stressors, whether that's generalized anxiety, depression, or obsessive-compulsive disorder, is usually necessary for a true resolution. Because if you don't treat the anxiety, the itch-scratch cycle just migrates and restarts somewhere else.
It really does. So moving from mechanical friction, let's look at microbial imbalances. This brings us to Seborrheic dermatitis, or SD. Here we're focusing on the commensal flora, the microscopic organisms that just naturally live on our sebaceous, rich skin.
Okay, so this yeast is everywhere. It's on you, it's on me. But why does it suddenly cause a disease state?
Well, the pathophysiology is heavily driven by Malassezia species of yeast. These yeasts naturally live harmlessly on our skin, like you said, but in seborrheic dermatitis, the local environment shifts. The yeast begins degrading the sebum, which is the natural oils of the skin.
Okay.
As they consume the triglycerides in the sebum, they leave behind these really irritating unsaturated free fatty acids.
So the yeast eats the oil, leaves behind acidic waste, and the skin just freaks out. It triggers an inflammatory cascade, disrupting the lipid balance, which causes the skin to rapidly shed.
Exactly.
And that presents as a classic, greasy, yellow scale crust. It's a very specific, recognizable look. And for the MCCQE, seborrheic dermatitis is an absolute goldmine because it has a bimodal presentation.
It really does.
It strikes in two very distinct age groups, and you need to know the nuances of both. First up, infantile SD, which happens almost exclusively in the first 3 months of life.
Yeah, the classic presentation here is what parents call cradle cap. It's firm, greasy, yellowish scales just clinging to the crown and frontal regions of the scalp.
And let's contrast this with infant atopic dermatitis, which we talked about earlier.
Yeah.
Unlike infantile AD, infantile seborrheic dermatitis frequently affects the diaper area.
Right.
Why? Because it's a sebaceous, warm area where yeast absolutely loves to thrive.
Yeah.
Furthermore, it is usually completely asymptomatic. The baby's happy, eating well, totally unbothered by the rash, while the parents are incredibly anxious. Thankfully, it is entirely self-limiting.
Then we have the second peak, which is adult SD. This is a chronic, relapsing, and remitting condition. It presents as folliculocentric salmon-colored plaques.
Okay.
And because the yeast feeds on sebum, it selectively hits the most sebaceous areas of the human body. So the face, specifically the nasolabial folds right around the nose, and the medial eyebrows, the scalp, and the anterior chest.
Right.
The mildest non-inflammatory variant of this epidermal hyperproliferation is pityriasis capitis, which most people just know as standard dandruff.
Okay, time for a massive red flag exam trap. Listen closely to this one. Say you get a clinical vignette featuring a 40-year-old adult who presents with sudden onset, unusually severe, explosive seborrheic dermatitis that's suddenly spreading and not responding to over-the-counter dandruff shampoos. What underlying systemic condition must you immediately suspect?
You absolutely must suspect HIV/AIDS. The baseline prevalence of SD in the general population is around 5%, but in patients with AIDS, that prevalence shoots up to 85%.
Why such a massive jump, though?
Because the immune dysregulation is so profound, the systemic drop in CD4 T cells means the local skin immunity just plummets.
Dang.
The Malassezia yeast essentially throws a party and proliferates completely unchecked by the host defenses. If you see sudden explosive SD in an adult, you need to expedite HIV serology. I should also note there's a strong, highly tested association between severe seborrheic dermatitis and Parkinson's disease.
That feels so random. What does a neurological movement disorder have to do with facial yeast?
Well, it comes down to autonomic dysregulation.
Hmm.
Parkinson's patients often have significantly increased sebum production seborrhea, which provides an absolute feast for the Malassezia yeast.
The skin really is a window into systemic disease. That is wild. For management, since we're dealing with yeast and inflammation, we target both. For the babies with cradle cap, keep it highly conservative. Just soften the scales with something gentle like sorbeline cream or mineral oil and gently remove them with a soft baby brush. For the adults, topical antifungals are first line to drop the yeast population. We use things like 1 to 2% ketoconazole shampoo or 1% cyclopirox. You supplement that with mild, intermittent topical steroids just to cool down the acute inflammatory flares.
And the key patient education point here is that it's really about maintenance. You are not trying to cure it. You're managing the microscopic flora to keep it at a tolerable baseline.
Okay, we have covered some serious ground today, and we went really deep on the mechanisms. Let's do a rapid-fire takeaway summary for you to solidify this before exam day.
Let's run through it.
Atopic dermatitis is an endogenous barrier and immune defect. It is linked to filaggrin mutations, driven by a Th2 to Th1 shift, and favors the flexures in adults. Contact dermatitis requires a careful timeline history, immediate direct chemical toxicity for irritant,
Right.
and a delayed type 4 T-cell hypersensitivity for allergic. Lichen Simplex chronicus is the localized hyperkeratotic manifestation of a chronic itch-scratch cycle, found only in areas the patient can physically reach. And finally, seborrheic dermatitis is the greasy, Malassezia-driven rash favoring the face and scalp, fueled by sebum, with crucial diagnostic links to HIV and Parkinson's.
Keeping those mechanisms straight is exactly how you rule out the distractors on a really tricky multiple-choice question.
So, I want to leave you with a final provocative thought to ponder as you review your dermatology notes tonight. As we learn more about Malassezia yeast degrading lipids and seborrheic dermatitis, and Staphylococcus aureus colonization constantly undermining the immune response in atopic dermatitis, are we shifting from treating the human skin itself to basically acting as park rangers managing a delicate, microscopic ecosystem living on top of us?
It really reframes our entire approach to the specialty, doesn't it? We aren't just repairing the fortress walls anymore. We are actively managing the wildlife living on them.
Keep studying hard for the MCCQE. Mastering the specific clinical patterns, the timelines, and the underlying why behind the symptoms is the absolute key to having total confidence on exam day. Trust the process, trust your preparation to keep that fortress strong.